трансляции из операционных. Выключаем звук и переходим к дискуссии. У нас есть на это полчаса. И let me speak English once more. We have just seen the Boston Scientific fantastic visualization of the introductory structures and the storm. And may I ask, not the clinicians at the moment, but fortunately today we have the Ingolf von Rembabin from Olympus company, and I believe that Olympus engineers are working on their own new baby scope, but probably it's under the absolute secret at the moment, Ingolf, right? So let us postpone it to Olympus engineers and let us discuss some questions which are still from the first presentation. May I shortly ask all the experts here, are you usually add adrenaline to your solution before making MRI? Let us start from Sekiguchi sensei. Just short comment. Do you add adrenaline to your solution during the MRI or ESD, or you use it without adrenaline? И свет можно сделать побольше.
Usually without it.
Without adrenaline. And you think it's not necessary in the most of cases?
Routinely not necessary.
Routinely not, yes. Yaroslav, Warsaw.
In our unit, also not using adrenaline routinely. Yeah.
No. Michel.
I only use adrenaline for ampulectomy.
For ampulectomy.
Ampulectomy. I find that very useful for the ampulla.
In all other cases?
Typically not.
No. Виктор Владимирович, используете адреналин для инъекции? Не используете? Кирилл Вячеславович?
Никогда. Но и принципиально мы против вообще адреналина. Мы хотим видеть кровотечение во время операции, если оно таковое есть, а не когда тебя позовут через 2 часа из дома на кровотечение после полипектомии.
Ну и еще один аспект. Yes, please. Можно микрофон, пожалуйста, дайте профессору Гральнику. Пока микрофон мы доносим, еще... Спринтер, да. Yes, please.
Thank you. We actually do routinely. So we'll take 100 milliliters of gel fusion. We add 3 cc's of indigo carmine and 1 cc of 1 to 1,000 epinephrine. So it's a 1 to 100,000 dilution. We do what Michael Burke does.
Yeah, Chris?
It's an important point. I was using in the past, but nowadays I don't do it, especially in the colon, for 2 reasons. One, we did a case report where the patient developed acute MI post-EMR of a large polyp which we resected in the rectum. And also we noticed in one of the cases who patient went for surgery, eventually after resection, noticed a lot of tissue necrosis where incomplete EMR was attempted. This patient, I think the patient had lap-assisted resection finally. And so these are the 2 things which resulted in me not doing it. Having said that, I tend to use it in the duodenum where there's a lot of bleeding, and also when I'm doing the ampulla where you need a clear vision there.
Итак, подводим короткие итоги. 7-1 в пользу того, чтобы не использовать адреналин при выполнении диссекции и резекции, за исключением ситуации при работе в дуоденум, особенно при ампулэктомии, где кровоснабжение самое интенсивное. И аргументы в пользу этого, то, что сказал Кирилл Вячеславович, справедливо, лучше кровотечение получить во время удаления и остановить его, чем ночью оно разовьется и надо будет приезжать или будут вызывать. И то, что сказал профессор Рагунат, что описаны случаи, когда после введения раствора с адреналином, не будем анализировать, связано ли это с концентрацией адреналина или нет, факт тот, что описаны случаи, особенно в толстой кишке, некроза стенки кишки в результате введения адреналина. Так что на то, что называется рутинно, его использовать не рекомендуется. Все-таки так у нас получается мнение большинства экспертов. And one more question from the first part. One of the colleagues asked me about the underwater polypectomy or underwater MRI. What's your approach? Have you tried, and what's your impression, let's say? Are there any advantages of underwater MRI or polypectomy?
Yeah, actually, we have sometimes tried underwater EMR, particularly the lesion located near the appendiceal orifice. In that case, using the underwater technique, we can see the demarcated line near the appendiceal orifice. So in that case, underwater EMR can be effective. I think that except that actually we prefer using the conventional EMR technique or ESD technique.
Thank you. Yaroslav?
In our unit, our endoscopies don't use underwater technique at all. But I agree that there can be some situations, and especially by some centers, it's promoted. But we don't use it.
Yeah. Michel?
Yeah, I don't use it. I like to do procedure dry.
Dry. Okay. Also without blood. Виктор Владимирович. Микрофон.
В слепой кишке очень хорошо, не нужно вводить инсуфлирующий воздух или ЦЛ, очень удобно.
Во всяком случае, надо подчеркнуть, что работа под водой, мы иногда боимся, да, что будет расходиться электрохирургический ток, вызвать глубокое повреждение. Во всяком случае, все работы, которые те, кто предпочитает так работать, говорят о том, что такого опасности нет. Кирилл Вячеславович, пробовали?
Ну, рутинно не используем, но так припоминаю, что пару раз пытались. Ну, что-то сейчас пока не могу преимуществ для себя понять.
Ну, там еще есть, насколько я понимаю, идея подводного вмешательства, что немножко приподнимается образование и легче его захватить, что называется, вместо мышцы, да, немножко подлежащие уходят. Would you like to add, Chris, or
We don't routinely.
you don't use?
No, we don't. I've seen actually, I think we may be starting to move more and more to piecemeal resection using cold snare only, and we may see more use of underwater with cold snare.
Yeah.
Because it may be safer.
Chris?
I agree with Michelle that I'm not sure exactly whether it's going to be of a great benefit to do underwater EMR. Yes, it has been demonstrated it's been demonstrated that it can be done reasonably safe. But I'm not really confident that it can be done in all circumstances, and when you have a good technique of injection, resection, and you can see a nice good plane, you're already doing it, so there's no need to change your practice just because it can be done.
Thank you very much. Я хочу сказать аудитории, что у вас есть, вот так же, как вот эти два вопроса были заданы в перерыве, у вас есть уникальная возможность задать один вопрос сразу 7 экспертам со всех концов света. Поэтому, если вас что-то в своей практике волнует, подходите к микрофону, инициируйте. Если вопрос интересный, будем спрашивать у всех. First of all, I would like to emphasize that, of course, it's easier to discuss life than perform it, especially not in your own hospital or in your normal routine work, but on the live course when large audience looking for you. But I personally was not impressed. Sorry for Thomas, I was not impressed with this device. What's your impression? And let us discuss generally about the second hand. What the approach is with the spring, with the rubbers, and so on and so on. What do you use in your daily life to triangulation and to lift the tumor to facilitate dissection, for example? Michel.
So I like the tunneling technique. I mean the technique where you create basically a pocket and you go behind the lesion and you go all the way through and then open on the other hand. You may also, in combination of that, use, once you have the tunnel, a clip that you attach to one of the border and apply some traction. I think that's a very elegant technique.
I'm sorry, apply traction by the
From the
thread,
outside.
by the thread or
By the thread.
by the thread?
So I think it's very elegant, but the basic principle is using the turning technique. The device that they were showing is now called the ORISE device. It's a device.
Once more.
ORISE. O-R-I. ORISE. S-E.
All right.
It was acquired by Boston Scientific. And the idea is to provide triangulation. So it's a device that will function as an overtube over the scope,
Yeah.
and has two lateral channels that allow you to grab the lesion while you keep the endoscope in the center and apply traction. The big problem of this device is doesn't allow you to go very deep, so you can only restrict it for rectal and maybe rectosigmoid lesion. Anything further down, you can't get the device there. That's the biggest problem. The second problem of the device, it opened like a parachute, so it allows you to work in a closed space,
Like a tent.
like a tent. The big problem is if you're dealing with a very large flat lesion, it doesn't allow you to basically capture the whole lesion. So you have to work, in phases. Phase 1, you do half of the lesion. Phase 2, you do the second half of the lesion. But I believe I've tried it. The biggest limitation is our inability to push it further down from the rectosigmoid junction. So if for large lesion or for lesions that are very deep, I still prefer conventional ESD
Yeah.
with the cap.
Michelle, what about the degree of freedom which this device gives you in your manipulation?
It is you have to have your assistant actually manipulate the two rattus that's going to give you the traction. So it's not really a freedom, is you basically have traction that allow you to speed up the procedure. I don't think the device is basically a game changer. It's probably gonna speed up your procedure. It's gonna make it faster. That's how it is for very specific small lesion in the rectum and the rectosigmoid.
What about the risk of perforation? Is it higher or lower?
When you advance the device into the colon, you have to make sure that you all constantly keep vision. You are tempted to advance the device. You're tempted to advance the device deeper, like you advance a catheter over the wire, but you have to be very careful. You actually always have to keep vision, or you will have a perforation.
Thank you. Krish would like to. Please.
I have seen this device and used in big models, but not in real life. As Michelle says, you feel a bit claustrophobic working with it because you don't have much space to move around. And also, when it opens up, sometimes it's a bit unpredictable how it opens up, and I felt a bit cumbersome. And probably with further developments, then it may get better. The current way of doing ESD, many of the endoscopists have moved on to doing the pocket creation method because that gives you a bit more control, and also the fluid doesn't run away when you're cutting around and doing it. And currently, a lot of my ESDs, I'm using the pocket technique, but most of them I do the upper GI and esophagus. It seems to be fine. In combination with the SB knife, it works very well, where you can create a nice good tunnel, go to the end of the tunnel, and then come back and use the SB knife like a scissors to cut all around it. So in combining one of the traditional knives along with the SB knife, it works quite well.
Thank you very much. And now we have a privilege to be on the direct connection with the Hamburg. Thomas Rosh is on the screen just at the moment. Thomas.
Hi.
We're here, and it's really a pleasure to be with you. We spent all this day together with you, and we feel it with our heart when you talk about Russians. And now we have the also the international experts, Sikiguchi Sensei from Tokyo, Michel Kacharek from New York, Yaroslav Regula from Warsaw, Poland, Jan Gralnik from Israel, and Krish Ragunath from UK, from Nottingham, and a lot of Russian people who came from all parts of our country. Welcome, Thomas.
So welcome everybody. I hope you enjoyed the morning and the transmission was smooth. And I'm here very happy to answer any questions which should have arisen.
Thomas, could you please a little bit closer to the microphone to listen to you?
Now better?
Yes, now it's better. Yes, thank you.
Now it's better? Okay. So I said welcome, and I hope you enjoyed the morning, and I'm happy to answer questions and discuss with you.
Thank you so much. Probably our international experts have also questions to you. Jan, would you like to add something?
Hi Thomas, it's Ian Grelnick. How are you?
Hi.
I actually don't have a question. I've been to EndoclubNord twice, and I just want to congratulate you. You guys put on an amazing course. It's so extremely well done, organized, professional. Kudos to you and your team. You do a fantastic job.
Thank you very much. So we have a great support from a lot of people, and we enjoyed it all year.
And you know, this year you are streaming again live to Israel. I'm not there right now, but I know that there were several messages sent out to the Israeli society, and I'm hoping that a number of the members of our society, the GI Society, have logged on today and have also followed from afar.
Good, right? We have a British studio with PSG members, endoscopists, and they are commenting the things which you see. So you have also seen some transmissions which I think did not go to the Hamburg people, but anyway.
Thomas, yes, Krish, please.
Thomas Krish here. Thank you very much. It was an excellent transmission, and it's nice to be with the Russian audience here. And at the same time, I've been in contact with the PSG studio as well to see how it's going, and also from a few other centers in the UK who have been seeing it in their hometown. So I think it's very professional, very good. We quite enjoyed the content, and we also had a lot of discussions after you finished the procedures here with the Russian audience, and we are quite enjoying the live endoscopy transmission from EndoclubNord. Thank you.
Thank you. I think from what I've not seen everything because I was involved by myself, but I think the greatest variety was in endoscopic resection techniques. From just the master Doug Rex taking a snare and blue fluid and off he went, to trying out sophisticated devices to perhaps make ESD easier.
We saw a range of cases from a simple endoscopic resection to complex one, including some prototypes what you've been demonstrating. So there is something for everyone who comes and watches this, from a basic endoscopist doing the everyday endoscopy to someone who's aspiring to be an advanced interventional endoscopist. So thank you very much for that.
Can I add one more point, Evgeny? I think what's really important, Thomas, is that what you started last year with going live online to different places around the world, you've greatly enlarged your audience, and you've created an educational event now that can be enjoyed by so many more people. And the course is so well done. It stimulated, I think, some great discussion here amongst the audience, and differences of opinion amongst the international experts. And again, I want to commend you for doing that. I think it's a great advancement for our field.
Thank you. I think it will be interesting whether there are, how many live demos there are in 10 years, and whether there are just live streams or people still coming, or both, or I think the group who has the best ideas for an online course, which is not just streaming and doing nothing else, will make the race long term.
Thomas, after the first part of your transmission, we are actively discuss here the necessity of soft coagulation of the ages of the post-EMR defect, especially if you are really confident that you remove it with the clear margins. We know that according to the prospective randomized trial, the amount of residual or relapses of the tumor is less, but we haven't the consensus about this. What do you think? Is it really necessary to perform in every case after EMR in the colon soft coagulation of the edges?
Well, there's nothing better than a well-done randomized trial, isn't it? And especially with recurrence rates, I think unless you test and really precisely know your own recurrence or residual adenoma rates, it's difficult to say, and that's the classic question for a randomized trial. So what I would wish is that other people, us, other groups, do the same. At least maybe if you know your recurrence rates in the last 2 years, you then start ablating the margins for, I don't know, 100 more cases, and in that uncontrolled and non-randomized way, see whether there could be any different. And maybe you will be surprised.
Yeah, thank you very much for your answer, Thomas.
And it's not difficult. It maybe takes 5 minutes more or 10 minutes if it's a large lesion. So for the time being, I just can recommend that other groups get systematic experience with this technique.
Yeah, that will be really interesting. Any other comments? Yes, please.
Although I am here in Moscow, I can assure you the whole Poland is watching, because we also obtained a link. As far as I know from my colleagues, they also follow your perfect course.
Thank you.
Sekiguchi.
Okay.
Please.
I'm Masao Sekiguchi, coming from Tokyo, Japan. I enjoyed the live demonstrations very much. Actually, I'm very impressed by the fact that the ESD itself has developed in European countries. However, at the same time, interestingly, I still feel the difference in endoscopic management between Japanese endoscopists and European endoscopists and the US endoscopists, particularly for the management of endoscopic treatment of colorectal lesions, piecemeal resection, or ESD, or like that issue. So I think that very interestingly, so there are many things to be discussed between Japanese endoscopists and EU endoscopists. So that's my comment. Thank you.
That's true.
Oh, thank you. I mean, what we have seen in the West is a huge marketing wave towards ESD in the colon. Still, it seems to be forbidden to do a randomized trial, because at the end what counts is the final outcome. And otherwise, we are, for about 10 years, we have been having these religious and philosophical and heated discussions. And what's going on, of course, and this is what we wanted to show you without stating that this is absolutely necessary, that there might be new devices, perhaps making ESD less complicated. We don't know yet. So this has to be tested as well. But the basic question is not answered. There is a Dutch randomized study in the rectum. We are doing a randomized study in the rectum, which is slowly progressing. But that's, again, a classical question, because it's final outcome. After 5 years, how many recurrences, how many cancers, how many colonoscopies? And only then you can really decide whether there's a difference or not. Theoretically, there are advantages of ESD. It's always better en bloc. But there are downsides as well, and we're still exchanging the same arguments as 10 years ago.
Yeah, thank you for your comment. I totally agree with you. So we need to collaborate together from now on. Keep on collaborating together.
You guys should do that. You are very experienced in ESD, and please do a randomized trial in the colon.
Yeah, of course.
You must have thousands of cases,
Of course.
experienced examiners for years.
Yeah, including Japanese senior doctors, we believe that the evidence itself is very important in addition to the technical issues. So we believe that we can collaborate together. Thank you.
Yeah, hopefully. Because I think in the stomach and squamous cell carcinoma, it's okay, you can argue for ESD, but the colon is mostly benign. Barrett is very complex. You know, multiple lesions. These are the two areas. So please do a study in the colon, a randomized one.
Okay, thank you.
We agree, Thomas. Now, Michel?
Yeah, hi Thomas, Michel. Congratulations, fantastic course. I actually don't have a question, I just want to congratulate you and I wonder how can you obtain such a beautiful transmission? I felt like I was in my living room watching those cases.
Well, we have a very good transmission company, and actually what we are doing, we are very carefully preparing the cases. And in the days before, we are thinking very precisely which sequences we are going to show and what the message should be. So like with ESD, with the new ESD devices, only showing the principle and not showing the full ESD, because otherwise people are bombarded with ESDs. And we have been doing this for 25 years.
I know there's some endoscopic suturing going on. Is there a lot of endoscopic suturing happening right now in Germany?
Not yet. I think there are some indications like, you know, occasionally you have to fix a stent. Occasionally, not every stent, for God's sake. And what's the most interesting area is a endoscopic gastric sleeve. I think there are some results coming out, but I think that's an area we should invest our energy in and do good studies and see what's the long-term outcome.
And what is the main center you think doing endoscopic sleeve gastroplasty right now in Germany?
Well, there's no center who does large numbers. The main problem is reimbursement. So it's not reimbursed. Even the surgical sleeve, you have to apply at the medical insurance for every individual case and get individual approval. So you can't just admit patients and do it. And that's an obstacle, even to do studies, because they are smaller companies, they don't have so much money to fund a $2 million trial, etc.
I see.
Yeah. Jan, please.
Thomas, it's Ian again. I want to challenge you with something.
Please.
I have a great interest in bleeding, and I give talks a lot of places on bleeding. I'm disappointed with live courses today as compared to 20 years ago that it's very rare to do live demonstration of bleeding patients. And I think it's unfortunate. It's the most common reason we as gastroenterologists are called in for emergency situations. And you can give all the didactic lectures you want, but there is great variability on how we perform endoscopic hemostasis. So I know you stand up to challenges. I would like to see you and your colleagues in future years, however you can, arrange for some cases that will show demonstration of endoscopic hemostasis to the audience. And it may be not as sexy as some of these other things, but for our field, I think it's exceedingly important for people to see experts performing endoscopic hemostasis and answering questions about techniques and what's appropriate to be done today. So that's my challenge to you. And I've known you for many years, and I know you stand up to challenges.
Yeah, I'd like to. I mean, even if you are really longing for a case, it has to happen on that specific day in one of the 3 hospitals.
Agree.
We did not focus on that actually, so probably these cases might be done as an emergency on the site. So we'll discuss that for future years. Another interesting idea for the bleeding would be if we go for online courses one day, then if we all agree there's a specific day and we have 20 possible hospitals, and that unit with the bleeding comes forward. So I think to increase the likelihood, you need a larger number of centers.
So you've already started to take care of the problem.
From one place to the other, I think this opens up new possibilities.
I think that's a great idea. I just wanted to throw it out there for you as a challenge.
Yeah, thank you. So I'll bring it to my colleagues, and maybe next year we'll be watching out for the bleeding patient.
Okay.
Yeah.
Fortunately, most of the bleeding patients don't actually bleed, so the majority of emergency endoscopies, there might be a little bit of blood in the stomach, but not an active bleeding or no clear bleeding source. But if you don't try, you will never get one. I agree.
Please.
Thomas? Hello, Professor Rosh.
Hi.
It's me, Katerina. I have a great wish to thank you, to thank all members of your team for this great opportunity you give us. So it's actually it's amazing. We've got and we do it for the first time, and it's really interesting that we combined two countries, two cities, several hospitals, several meetings, so several countries in one. We want this big holiday of endoscopy. So I appreciate it. Thank you very much. And we all applaud to you. Thank you very much.
Thank you very much, Thomas.
Great thanks to you. Thank you very much.
We wish you all the best for the rest of the day and tomorrow. Thank you so much, and see you soon.
Thank you. See you. Bye-bye.
Thank you. Перерыв до 16:00.
Можно по-русски сказать два слова? Большое спасибо Томасу Рошу, что они нам показали работу известнейшего специалиста в области эндоскопической